I got to see these ICU directors.
Hey, good morning. This is Steve Stites, Chief Medical Officer here at the University of Kansas Health System, broadcasting live with you from the Dall Simons Family Studios. Delight to be back with you this morning. Hawkeye, what do we got?
You know, numbers are stable, so I think that's good in this case, and the fact that they aren't going up to above 90, 100, above 100. We have 89 acute infections in the hospital right now. 47 of those, though, are in the ICU. So we are seeing kind of a creeping proportion being in that critical care ICU mode. And of those 47, 26 are on the ventilator. So still a high proportion compared to, earlier on it was maybe 10%. We are getting up there.
We are.
We still have 64 in that acute or recovery period that are still here in the hospital, so 153 patients. Hays has bumped up just a little bit from where they were yesterday. They have 33 infections, 29 are those active acute infections, and then 4 in that recovery period.
How many of our recovering patients are still on the ventilator?
We have 6 people on the ventilator still.
So that's still a pretty big number. What's that give our total COVID-related ventilator number at?
That would be 32.
It's a lot.
So that's a lot of ventilator.
And I expect some of our team are feeling that. Joining the up-to-date today will be Dr. Catherine Satterwhite, the Regional Health Administrator for the U.S. Department of Health and Human Services, and she somehow is related to the next person, Lewis Satterwhite, a critical care physician, and psychologist Danielle Johnson. Lewis, actually, all these good folks have been with us before. Welcome back to all of you. We will continue our public course on all things vaccination related. Well, before we get into any questions, et cetera, Jill, are there any questions from reporters out there?
We do. One of them has to do with, there was news out of the UK. Fox would like to know, there was news out of the UK about severe allergic reaction. Can you speak to that?
You bet.
To the vaccines they were giving yesterday.
Yeah, yesterday was like vaccine news day. If you read about it, it continued into this morning, right? Because in the early part of the morning, we saw that the FDA had started talking about Pfizer and saying they had met their endpoints for success, and they meet tomorrow on Pfizer's vaccine. Then later in the day, in Lancet, the AstraZeneca trial data was published. It was the first time we've had all the data published. And then this morning, reports are coming out from UAE where they have been using a Chinese model, which is an inactivated coronavirus, as I understand it, showing some pretty significant effectiveness. So, man, bang, bang, bang. 3 big things came out about vaccinations, that's great that it's all coming out. Yeah. But what about the severe allergic reaction, Dana?
Yeah, just all these news stories are moving at light speed.
They are. Warp speed.
Warp speed. Well, yes.
Yes.
Warp speed here, light speed everywhere else. I think it's interesting. We know that, so there's just a very little bit of information, but it was 2 patients out of thousands that were vaccinated in the UK. Those patients had specific issues and had previous issues with allergic reactions to things and had EpiPens on them. So I think we really need to get a deep dive into what they had an allergic reaction about. I was able to read one of the FDA briefings on the Pfizer information yesterday, only the 60-page one, not the 90-plus page one. But looking at
slacker.
Right, I just got too tired. But looking at the important thing that I was looking at was that safety information, and a large proportion had local site reactions, meaning just kind of discomfort. That was mild, moderate, severe. Most of them had mild to moderate pain. That's nothing unlike we didn't get with the influenza vaccine, so I think that's not a big deal. There was a very, very small proportion that had anything like fever. That was a very small proportion, I believe 5 or 6%. Probably about 14-15% had fatigue. But as far as severe or life-threatening reactions, it was really like 0.1 to 0.3%. And they didn't even specify was that actually due to the vaccine or not. So I think we still need to get more information from this event or these events in the UK. But look at these specifically. But we also understand that with new medicines and new drugs, and really any safe or approved vaccines, these allergic reactions can happen too. So.
And what would you say for a vaccine would be, could that kind of allergic reaction with influenza happen, or measles vaccine, or
absolutely.
MMR? I mean, that's a very low percentage, really.
It's a very low percentage. In fact, we know when we give the shingles vaccine in the clinic, you have to sit and wait around for 10 or 15 minutes as well, because there could be that possibility. And that's an FDA approved one. And again, that's just a piece of the virus too. It's not the full virus. So I think it continues to look safe, very safe based on the published data. We need to really deep dive into these specific cases and see what exactly the component was. We have to remember too, the nice thing about this is they very boldly state this is a preservative-free vaccine. So there are very few components in this vaccine as well, the Pfizer vaccine.
Of course, it is frozen. It's like getting a popsicle, right?
Right.
It does have to be rewarmed. Okay.
And I kind of jumped ahead and was doing the reporter questions that were texted to me, and I think there might be reporters on the line. I apologize. Anybody on the line want to talk?
Yeah, that's okay. Hey, Cody from Channel 9.
Hey,
hi, everyone. We know when we were talking about Thanksgiving gatherings and travel and all that you had kind of written down, I wrote it down too, December 10th, that's tomorrow, as the day you're really going to start to expect a surge. What's being done behind the scenes to prepare for this? Are you starting to see those numbers tick up? I know you say your hospitalization is stable for now, but I'm just trying to gauge what you guys are going through right now.
You bet. I would say this, Cody. I would say that we are critically stable right now, and we'll hear about this from Dr. Lewis Satterwhite in just a moment when we start talking about how the ICU teams are doing, because that's perhaps where our greatest stress is right now. And we've prepared for it by really creating quite a bit of surge capacity. We've opened up other ICUs, and we've had some of our anesthesia team, who are critical care docs, take over some of the medical ICU folks. I mean, we've been working really closely together as a community here at KU to try and be prepared for that. And so I think that's probably the number one thing. And the second thing we've done is we've slowed down our surgical schedule. So that created more bed capacity here in our hospital. And also that helped our staff, because our staff was getting pretty darn busy and pretty darn tired because of all the patients we've been taking care of. And I think that was it. We had to do some things to try and pull the throttle back just a little bit to try and create a little more capacity here. I know that other hospitals in Kansas City are doing the same thing, and I think that's been helpful to all of us. The chief medical officers, we continue to be out there pitching about, it's so important to have great public safety because, and follow the pillars of infection control, because those are the things that we have available to us until vaccination becomes available, and we think it's going to be here next week. So, we're feeling like at the moment that we have things. I'm not going to say that we're under control, because that would be a misleading statement. But I think we are coping with where we are. The real question will be, and I'm going to turn to Hawk here. Hawkeye, this is going to be like other events. The first ripple starts now, because it's 2 weeks. That would be normal. Yeah. We've actually had a few patients who we have identified have their illness started with a Thanksgiving event. Yeah. And it was pretty clear that's where their exposures were. But that's the start of the rise, and we really won't know now for 6 or 8 weeks the full impact of Thanksgiving, which I think is what we also saw with some other events. Because if the younger folks are spreading it first, then it's just a ripple effect to where it goes. The counter to that is masking has really picked up. I have to say, when I go out in the community, I think people are doing a better job of mask wearing. I think that's really good. I'm not sure if that's really true in the rural areas as much, but it's certainly true here in the metro. And the second thing I would identify is that I'm hopeful that people took some of the warnings around Thanksgiving to heart, and perhaps did a little better with masking and having smaller gatherings. Hawk? Yeah,
I would agree too. I think the concerning thing is not necessarily the restaurants in those places. We know that there is risk there, so I'm not saying that. We know that there is risk there. If you're taking your mask off to eat and you're in an enclosed space, wherever that space may be, that's going to be a risk. But it's really about the small gatherings or the home gatherings. I have a family friends that contacted me yesterday. Now 2 out of 4 people in that family household have COVID-19, but they don't necessarily understand where you got it. So that's the other issue too, is people don't always understand where they get it. And as we move into that, further into this holiday season, and people are getting together with people outside of their normal household, that can happen, and you can have spread that way as well. So I think even when we first looked at after the reopening and Memorial Day, we didn't see really effects until 6 or 8 weeks later from that, and that was fairly well documented. So we still are taking it one day at a time, but just like you said, we are coping the best we can.
Other questions out there from reporters?
Yeah, this is Brian Grumman with the Kansas News Service. The state of Kansas is about to reach 2,000 deaths. It took a lot shorter to get to that second 1,000 than it did to get to that first 1,000. And I know when we talk about deaths in COVID, the death percentage overall is very low. So how should we think about hitting another one of these milestones and doing it much quicker than we did the first 1,000?
Yeah, that's a great question. Well, first of all, we should think that that's not good news, right? It's not good news to think that the death curve is accelerating, which is true across the United States. That's not just a local phenomenon. And I'm going to pull in a couple of our guests here a little early. Let me first turn, and we're going to get into the more official part, but I just got to turn to these guys because they're going to have some thoughts about that. Catherine, you got to be watching that stuff with HHS, that stuff, what a great term. The data around the mortality curves in the United States. Thoughts about that?
I think we've actually touched on a number of things. We know that there are, while we're doing better on a lot of our mitigation measures on the pillars of infections, like you talk about, Dr. Stites, it's still getting colder. We know we're still going to be inside more. We know that people are really, really tired. So yes, we're watching it, and the ways that we can impact that are to continue to take a lot of personal responsibility for protecting ourselves and our neighbors and our family, and following the lead of our local public health authority. So yeah, I don't have a magic answer. I think it is really sad. I do think we still have an opportunity to impact that, and that's really important to know that this is not inevitable, that we can take steps to, again, flatten the curve. Kind of, we haven't used that language so much now, but we can still do that.
Yeah, and I think, really what it signifies, and I'm going to come back to Dr. Lewis Satterwhite in just a moment, but Dana, what it really signifies, I think, is widespread community transmission.
Yeah.
There's just so many more people getting COVID right now that inevitably that's going to lead to more death. And I think those curves, we know they track, one follows the other.
Yeah, and I would agree with you there. I think, just as Catherine had said, we have gotten better at first of all, the mitigation, so hopefully stopping the spread. But people still don't understand where they have gotten, even if they have been tried to be as vigilant as possible. The other things that we've done is when you do come to the hospital, and again, it's a smaller percentage. We have always said 80 to 85% of people will never need to seek medical care. But if you do, it's a small percentage. Our supportive measures, the proning, the trying to not ventilate you unless you absolutely need it, the anticoagulation, the dexamethasone, the remdesivir. I don't think the monoclonal antibodies have had a chance to really have an effect yet because they're so new. But doing those things that we've talked about, our mortality rate, if you look at Johns Hopkins, really the mortality rate has probably stayed the same, 3 to 5%. Our mortality rate here in the hospital has stayed the same. But when you talk about the actual numbers, we've had more infections. So even those small percentages become much larger numbers when you have much more infections. And that's what we're seeing. I think it's a consequence of the actual numbers of infections.
Lewis, this has got to be hard up in the medical ICU right now because you guys, this is a tough lung disease, and patients don't do always all that well when they're ventilated, and there are a fair number of deaths. Talk to us a little bit about the impact on you and on the staff and on the nursing staff and respiratory therapy staff in particular.
Thanks, Steve, and thanks for having me this morning. You are exactly right. This has been difficult since the spring, but it has been palpably more difficult over the last month or an even couple of weeks. I think you've got some video streaming of some of our nurses and providers doing some of the day-to-day care in the ICU going right now. And it's difficult because we are seeing more deaths. The numbers that you guys have talked about so far on the national level, on the state level, we feel it very much locally. We are dealing with more deaths in our ICUs on a day-to-day basis, and that takes its toll on everybody that interacts with patients and families. And everybody's doing it and doing more shifts. Everybody's picking up overtime, stepping up to do more work than they've done before. and each of those shifts can be even more draining than the last. So I think we are so fortunate to work with the people that we do work with. I've said to a number of people over the last several weeks, I would never, ever want to do anything like this again. But if I did have to, I'd want to do it here and with these partners. So yes, everybody in the ICU is feeling the impact, but at the same time, really banding together and trying to come together and support each other.
All right. Are there any other reporter questions?
I have some, but I know we have 4 or 5 on the line.
Not hearing any?
Yeah. All right. So the KSHB wants to know, how will folks know when it's their turn to get the vaccine? Do they have to be proactive and reach out to the doctors, or will the healthcare providers tell them?
All right. Well, I tell you what, to answer to these questions, I think we can do a little more formal introduction of all our folks here. What do you think?
Okay.
Because we're going to get into vaccine. Let's first of all talk. Catherine, let's begin with you. We're going to come back to this really important question, but the logistics of getting the vaccine from the factory to the front lines here and across Kansas, I mean, really, HHS has had a big role in that, about how it's being allocated. Talk to us a little bit about the strategy and what's going on for vaccine distribution, and I want to get also into how we're going to get into Black, Latinx, and Native American communities where there's been a history of maybe experimentation and people may not trust things as well. And then we're going to turn to Danielle in a minute about that.
I feel like I could talk for 2 hours on the things that you just said.
I know you could.
Let me address the question on the line first, and then I'll wrap it around into logistics. So the state health departments, so both Kansas and Missouri, are working, around the clock, pretty much every day, to try to figure out the best way to communicate to the public about when it will be their turn for the vaccine. So you will know there will be media outreach, your providers will be informed. I think we can already see right now that the world is being flooded with vaccine information, but it will get more specific, and you will have visibility as to sort of who's eligible to get the vaccine when. And so when we're thinking about logistics, going back to the original, to Dr. Stites' question, what's happening is the vaccine, so right now Pfizer is the vaccine that we anticipate being able to be administered next week. So just days from now, which is fantastic news. It's being manufactured and it'll be shipped directly to the facility that will then manage that administration. So the state is deciding what facility is going to get it. There are a whole bunch of criteria that go into that, including whether or not the site, the facility that's going to administer, has storage capacity. We know that Pfizer vaccine has to be super cold, and not everybody has that capacity. And those sites are going to work with partners in their areas to then vaccinate what we're calling sort of the first phase of eligible population. And we know from the Advisory Committee on Immunization Practices, and I know you've talked about it on this program as well, that that's going to be healthcare workers with direct patient care and residents of nursing homes. We also know that there's not going to be enough vaccine available immediately to vaccinate everybody. So there's two things. There's really supply, how much vaccine exists, and there's how many people we can actually put through the system, how many we can vaccinate an hour, how many we can vaccinate a day. So all of those things are part of the logistics of getting the vaccine out. And what we really want to do from a federal perspective and also from a state perspective is make sure that we're getting that vaccine to the right people and that we're not wasting any. And then wrapped around the whole thing is that we really want to make sure people have confidence in getting the vaccine, which I think one of our other guests is going to speak maybe a little bit about.
I think so. So, Danielle, this is a big deal. You've been with us before, and so thanks for coming back again. And I think we spoke early on, we were talking about the effect of COVID, especially in minority communities, many of whom the members of were on the front line or were essential workers, whether it had to do with food or delivery or what have you. And now we're in a situation where vaccines are, they're almost here. For all practical purposes, they are here. And we expect to start next week. but there's going to be doubt, lingering doubt, and not without some significant justification based on the history of experimentation, especially the African American community. How do we convince people who are most at risk that this is really a good thing?
That's a great question. I've been thinking about that over the last 6 to 8 months when we talk about the warp speed and if we're going to get vaccines out. And there's a significant population of people that don't trust the vaccine, the speed to which we've gotten here, the historical use of experimentation in medicine, minority population, and how can we trust that this thing is really going to help and not hurt us or experiment on us? And I think there's a couple of things. One being trusted resources. We spend a lot of time on social media, and that's not vetted information that we're all receiving or sharing. And so having trusted news sources that we know is going to give us the correct information, having a trusted relationship with your physician or your healthcare provider to know that you can call them, nursing staff, and ask these questions. I think we need to give space for patients to ask questions, to really have all the information that we know as providers to be given to our patients and to reassure them based on everything that we know that there's more inherent risks of getting COVID than there is of getting this vaccine. And being quite transparent with any of the side effects or adverse effects of taking this vaccine so everyone goes in really informed. And I think an underlying piece of this is to actually acknowledge our history, to acknowledge that I understand why this will be difficult for you to do given the history of how medicine has been utilized in certain communities of color. So I think acknowledging the past, being transparent with what we know about today and the vaccine knowledge, and giving the best information. I'm advising a lot of my patients to really restrict their social media use and their overall news consumption. It becomes overwhelming. And for those that are already anxious, depressed, and just kind of struggling with 2020, more news is not better. Right now, less is more. So being really mindful of consumption of information, being mindful of the conversations we have with our loved ones and our neighbors, to make sure that we're having conversations that are supportive, that are informative and educational, and not escalating some of the rhetoric that's already out there.
You know, I think your points are all dead on. The other one that reminds me is that, you know, as a physician, when you get to have difficult conversations with your patients, it's your relationship with that patient that matters, and that long-term relationship. And I think giving people the space to have doubt and then talking through that doubt is really important. And I think patients have to see you as their advocate in order to achieve that. Thoughts about that?
Completely agree. I think I will speak for that therapeutic relationship. My relationship with my patients is my bedrock. Doesn't matter, or shouldn't say that, but it's less important my theoretical orientation, but it's my ability to connect with someone and to really hear them, and for them to know that I'm actually hearing them. We may have some discussions around what they're saying, but to really hear that person. I think I've seen a number of patients who have gone to their primary care physician and didn't feel heard and didn't feel that anything they said was validated. And so even if as a healthcare provider, there's a disagreement, it needs to be discussed, because we know patients then will not come back to see that healthcare provider, and they may not go back to see anyone else because there's an overall mistrust that they weren't heard the last 3 times they went to the doctor. Why would they be heard this time? So Dr. Seitz, you're correct. We've got to have a relationship and the space and time to have a discussion that's really important, because it's their health, and that's for all of us the utmost importance.
And as we look at this, you know, relatively difficult time in America, you know, I'm struck by, you know, the images of George Floyd and those things, and you know, and I think, well, my life, you know, my wife's African American, and so in my home, Black Lives Matter, and in my life, and I think, well, how do we reach through some of the social justice concerns that are there to express that getting vaccines and being fair about it is a manifestation of social justice? I mean, to me, those things should be together, but I don't know. I think I'm struggling to even ask the question correctly. But how do we have the Black Lives Matter movement say vaccination is important to us?
I think we need everyone, no matter what organization you belong to, what affiliation you have, where you belong, that needs to be a banner on everything that we say and do right now, is that vaccines matter. We need our population healthy. And if we can't make any progress with social justice, with educational reform. We can't make any progress if we're sick. If we're all dying of COVID or sick with COVID, we can't make any changes in this world. So we all have to be healthy and vaccinated to really make our message heard about what's really important, so we can all come together and kind of fight for what's right in life. And I think everyone being able to get vaccinated and really understanding the importance of vaccinations. I think when we think about having children, we get our children vaccinated, and it's a no-brainer. I'm going to go get my kids vaccinated. That this is the same kind of ilk of I've got to also get myself vaccinated. But again, having trusted healthcare providers makes that possible as well, knowing that you can go to your ECP and have this discussion and actually say, I have some concerns about this, and have a conversation about it. It's going to be important. I think partnering with different organizations and having PSAs out there that say we stand with these organizations and we all stand for vaccination, to make this abundantly and explicitly clear the importance of everyone getting vaccinated and prioritizing. I know for the vaccine trials, there was a push to have diversity in those being in the trials, to make sure we had a best understanding of how different populations, genetic makeups would work with that. So I think we need to continue that, to say we are prioritizing frontline responders, and that's just not physician and nurses staff, but that's, people that are part of the janitorial staff or housekeeping, to make sure that everyone that's impacted by COVID is actually given the same opportunity to get vaccinated.
Yeah, I think that's exactly right. Well, thank you. So Dr. Satterwhite, I'm talking to Louis Satterwhite this time. You're in 5 ICUs. How many COVID ICUs did you have before this all started?
0?
Yeah, that's what I'm thinking too. How have you managed to get to 5 ICUs? How have you stretched the resource like that?
The first I alluded to in my first answer has just been a real partnership. We traditionally work in critical care across multiple disciplines that take care of patients with a variety of illness, and we've always worked well together, but for the most part separately. But everybody in the critical care world in our hospital has come together, and that's whether you work in nursing, respiratory therapy, one of our advanced practice providers, physicians, and whether you trained in anesthesia or surgery or medicine. Everybody is pulling part of the weight and pulling on the rope in the same direction. Specifically for the ICUs, our critical care nursing staff has picked up so many extra shifts and everyone is working in locations that are new to them. And from the physician and provider side, we have some of our anesthesia critical care folks taking care of COVID patients. We have our anesthesia critical care folks taking care of what would traditionally be in the medical ICU, in non-traditional areas of the hospital. And our acute care surgery critical care partners have also taken many of our traditional medical ICU patients, sometimes with some overlapping diagnoses, but sometimes just specifically to take some of the lift and the volume that we're dealing with. So a little bit of everything. We're in different spaces, working with different partners in different scenarios in every which way you can, but everybody is doing just a little bit more and trying to figure out how they can do their work and help the work of the person to their left and to their right.
When everyone does a little more, I just have to say, I don't know every other hospital's staff, but I know our staff, and to our nursing staff and our respiratory therapy staff, as well as to our docs and providers, that is a team, and it's a remarkable team. Okay, back to questions, Jill.
Yeah, Wayne with KLKC Radio has a mass question as it relates to the KDHE policy.
Okay.
The way that they understand it, the children that are less than 6 feet apart and have their mask on still have to be quarantined. It's also his further understanding that contact tracing has never found a case of such a situation where a kid less than 6 feet with their mask on has come down with COVID. He wants to know, why are we quarantining those kids, and should they change the quarantine rules?
This is definitely an ID question, Hawkeye.
This is a policy question too. So certainly we could start with the masking, and CDC or KDHE, it doesn't matter if both parties have masks on, if neither party has a mask on, or if one party has a mask on and the other does not. if you are within that time, you are still considered a close contact. So I don't know if that helps answer the question, but mask or no mask, if you are still within that space, you are still considered a contact. You know, I don't know that the policy is really made on the fact that no cases have been identified, but we do understand that this just has a clinical efficiency of spreading, and also that there is an abundance of caution to try and stop the spread, because we know that children can develop the same amount of viral titers and be able to spread it just as well as adults. So, you know, that is definitely more of a policy question, but that is just further consistency, because we know it is confusing for the general population out there when we have, you know, we had 14 days of quarantine, but if you were positive, it's only 10 days, things of that nature. This is just one more way to stay consistent, so it's a consistent message. If no matter if you're masking or not masking, if you're within 6 feet, you are still considered a contact. It doesn't really talk about different ages or anything like that. It's just hopefully one more thing to be less confusing and more consistent, because we know there are a lot of confusing aspects about this disease, the infection itself, the public health, all of those types of things.
I think it would be a great thing to refer to Children's, because I think Children's Mercy, they have some great expertise in this. They've helped shape some of the school policies, et cetera. And so honestly, I would defer to them. I think they would be better positioned to answer that question than I am. So,
and I can connect that reporter.
I think I would do that.
I think it's true. You know, we feel, and we've heard, you know, possibly even Dr. Fauci, there is a low amount of spread in the schools when some of those mitigation measures are taken, and that's de-densifying, that is masking, that's trying to space apart people in the schools themselves. So certainly there's more spread, even though when schools started, it's probably due to people getting together outside of the schools, in those households, those children being together outside of the school itself.
Okay, and last media question, then we'll move to the community questions for a few. Case TV5 is wanting to know, in regards to the Pfizer vaccine not being allowed to be offered more than the initial shipping until next summer, true or false, and why?
This is a public policy question, not, again, I think that the question is how many doses did we order? And so it's not so much a question of allowed, it's whether it's available. And so, Catherine, thoughts about that?
Yeah. Yeah, so the Pfizer vaccine is ramping up manufacturing, and it will be available for states to allocate every single week that it's made. So there are obviously decisions that happen, you know, what sites they go to, and again, what population is then eligible for vaccine. But the Pfizer vaccine will be available every week after the EUA is granted.
And there was some question, I think, about the doses that were ordered and whether we ordered enough or not ordered enough. And do you have any information around that?
All of the vaccine that is allocated to the states is being ordered. So there is not anything that's being left on the table right now. Every single vaccine that's being manufactured has a purpose and is going to be used. So like a KU, a site that would be eligible to get vaccine, has to work with the health department who is allocating that vaccine to each site. So the state health department says, KU, you are eligible, you can order up to X. And that ordering amount is based on all sorts of factors, including making sure that we have vaccine available throughout the state. And how to balance populations who are eligible, where people live, all sorts of things. So hopefully that helps.
Yes, and I think ultimately, as I remember reading over the last few days, that there's actually, we'll probably see more of the Moderna vaccine than the Pfizer vaccine. As I remember, we've got more, I don't know how you say this correctly, but more orders into Moderna than Pfizer. Is that your understanding as well?
Yes, it's not initially a huge difference, but we do think that there will be a little bit bigger quantity of Moderna available. And the other sort of really important thing, I know you guys have talked about this, is, and when we're thinking about ordering, you have to order the Pfizer vaccine in lots of 975. You can't order fewer than that, and you have to order a multiple of 975, whereas Moderna, you can order in units of 100. So we actually hope that Moderna is going to be really useful for some smaller sites, for some more maybe remote areas that don't have that ultra cold storage capacity. So they also have a little bit of a different role when we're thinking about a population-wide rollout.
And then after that, AstraZeneca and Johnson & Johnson hopefully will be coming into the picture as well. It's out there, so hopefully there'll be more. Okay, Jill.
Okay, so now we're going to move into some community questions. They want to know what kind of allergies, if you could talk just a little bit more about, do you know if it was peanut allergies or
there was no
specific
information
food?
in the public news story. It was 2 people out of thousands. They had a history of severe allergies. I myself did not understand what that means, because we know that you can have allergies to a number of different environmental or commercial or products, chemicals. So, hopefully they will be talking about that more and elucidating that more for the mass population, for the general population. But we don't know. The only thing that was in the article that I saw was just a history of severe allergic reactions, and that's why those 2 people did have EpiPens on their person at that time.
Yeah, you don't carry an EpiPen routinely, so you obviously have to have a history of an allergic issue. And again, that's true for any shot. And by the way, we are watching patients for 15 minutes, at least in this initial wave of how we're doing the vaccinations for COVID-19. You have to watch folks for 15 minutes after the vaccine to make sure they're not having an allergic reaction. Now, we don't have to do that with influenza, but we're kind of tried and true with influenza. This is a relatively new vaccine, and so as a result, I think that's a sound policy. And whether or not we always have to do that, I think will determine how it goes.
But we do it with a very safe vaccine, the shingles vaccine.
Yes.
So.
Yep.
Sue wants to know if Dr. Satterwhite would talk about the age ranges of those that are now in the ICU and if they have comorbidities.
You bet. Great question. So, Louis, we hear a lot that, patients who are younger don't get as sick, and it's only the old people who are really on ventilators and die. And I know that's not true. So talk to us a little bit about that.
Yeah, so I actually checked with anticipating that question yesterday and ran through our current patients in the ICU. So I wouldn't be able to speak across the whole hospital, but for our ICU population, yesterday we had 7 patients in their 40s. We did not have anybody in their 30s yesterday. We have had that through the course of the pandemic, but right now we had 7 patients in their 40s. Slightly more in their 50s. Still, the majority of patients are in their 60s and 70s. And the majority of patients do have some significant comorbidities and oftentimes multiple. I say that, and actually when I quote those numbers, I'm talking about those that are in where we have the bulk of our ICU patients, but we actually have 4 patients in a specialized area of our hospital where they're even on a different level of support beyond a ventilator. And those people are younger. Speaking in the medical terms, on ECMO, on a different layer of medical support, and we had 4 of those, and they are in their 40s as well. So we do have some very, very sick people in their 40s right now. Through the course of the pandemic, we've had younger than that, but we see it across a significant age range.
And I'd just say we've had some people who are sick. We've had some 18 to 20-year-olds. We've had a number of 20 and 30-year-olds. We've lost people in that age range as well, some of whom did not have other underlying illnesses. And Dr. Paulin was on the program yesterday, made a great point, which is even amongst those people who are young and asymptomatic, what we don't know, because they don't all go get care, is whether or not they lost a little bit of heart function or a little bit of lung function, because I think people are a little suspicious that you do. But we don't know that yet, and that's going to have to come out over time. But it may be that, let's say you do lose a little bit of your heart. Let's say you lose 3 to 5% of your heart function. You may not notice it unless you're a long-distance runner or a high, an endurance athlete, or your lung function may go down by 3 to 5%. We have a lot of reserve. We can tolerate that. But we also don't know what the long-term progression of that may or may not be. So, I think the idea that people are asymptomatic and they're not on ventilators is not the full measure of the morbidity associated with this illness. This is a bad virus, and it's not just bad because you land in the ICU.
So I was working this last week with someone in their 30s that had COVID-19 about 6 weeks ago, and was still suffering from fatigue and just not able to do the same workload at the same rate and having to take breaks and to lie down. And that's somebody, and statistics as we know them today, is going to be never required hospitalization, really didn't get that sick, but it's still impacting the daily life and their personal life and their professional life and every other way. So, we see it in the ICU. Certainly in some very dramatic cases, but like you talk about, Dr. Stites, there are many, many more people in everyday life where they are impacted, and we don't know, is that a few weeks, is that a few months, is that a few years, is that going to be a lifelong thing? So especially as we keep looking down this tunnel toward what we hope to be some longer term answers with a vaccine coming, it just reinforces those messages about infection prevention and the pillars of infection control.
Michelle says that on social media, it's circulating that Moderna and Pfizer have had death due to taking the vaccine. Is that true? Any reports of death
Well, I've
from
not seen
taking
that.
Pfizer
No, I
or
haven't seen
I
Moderna?
looked over the FDA thing briefly last night. You're right, it's very long. And the Pfizer one is even longer.
Yeah.
So, but I've not seen deaths due to the vaccine. You got to be really careful with what goes out on social
Yeah.
media. Also out on social media is that the vaccines cause Sterling. No, they don't. I mean, there's all these false rumors about that. So I think we should be very, 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 very careful with the stuff out
I
on
would
social
say
media.
I think that's why they're asking.
Stick to the
Yep.
FDA website, that
Yeah.
FDA or CDC. And then to Lewis's point earlier, about how this virus, how this infection impacts even healthy people who don't have to go to the hospital. It's very important. There's that story out about the world-class football or soccer star Paul Pogba, who won a World Cup, young, healthy. He had it in August, and since that time, he's continued to have brain fog and fatigue. And this is a finely tuned, world-class athlete. So just imagine the general public, even after getting it and not having to go to the hospital, certainly having these chronic issues for a couple weeks or a couple months is not to be taken lightly.
Catherine, have you seen anything about that as well? I mean, I know HHS is intimately familiar with a lot of the COVID and vaccine data.
No, I have not seen anything about that. I applaud you both. I've made it through the executive summary, which is a page and a half.
I'm not going to tell you, I retained a lot from last night. It was late.
Okay.
I know, it's like I got to go to sleep. No, I haven't seen anything. And I just want to reassure everyone, these data are being looked at by a lot of people very, very closely. One of the things that the FDA does is actually gets all what we call the raw data. So just the actual data they collect. It hasn't been processed. It hasn't been analyzed. So FDA, it's one of the reasons why it has taken some time between that application that was made on November 20th and the meeting that will occur tomorrow on December 10th. It's scrutinized heavily. So again, like Dana said, please, and Dr. Stites, please continue to look to FDA, CDC, state health departments, and trusted sources for your information.
Reva is asking, will Northwest Kansas healthcare workers be considered to get the vaccine, and is it dependent upon their local health departments to order this from the state?
Catherine, let's start with you, and then we can get into the question, I think.
It is not dependent on their local health department. The process is managed through the state health department, and the state for the past months has been enrolling different providers. These include hospitals, clinics, pharmacies, all sorts of different places that have the capacity to vaccinate. So the answer is yes. If you are a healthcare worker who falls in that top group, and like Dr. Stites mentioned, there might be some sub-prioritization. We might have to go into a little bit smaller group. For instance, if you are an outpatient, work in an outpatient clinic, you might not get to go until maybe after some of the people who are taking care of inpatients, nurses, techs, they might go first. But when you are eligible based on what job you do, you will be eligible. There's not a separate where do you live component.
Joanne says, when the shingle vaccine first came out, she says a lot of areas couldn't get enough vaccine for the second injection.
Yeah.
Is there any worry with that with the COVID vaccine? And she follows up with an assumption, I'm guessing one injection is better than none.
Well, that's, that's a question we really took on yesterday. There is evidence out there that the Pfizer vaccine has a strong effectiveness rate, even with one, but it's really the second vaccine that's important to boost you up to 95% and to keep your titers up a little longer. So I think you really want to get two. I know how we're looking at this. We're scheduling people, or in the process of starting our scheduling, and you're going to get one appointment and another appointment. And, we'll try and work with you to make sure you get both shots. And that's for our staff, because remember that there's a limited number of vaccines available right now. Right, we're not going to be able to vaccinate even all of our most essential staff and all of our frontline health workers. So, as an example for that, and Catherine kind of hit on this a little earlier, and we talked about it before the program a little. There have to even be some sub-analysis within the group. So let's say we have 20 vaccines and we have 100 healthcare workers who need it. Now the numbers are greater than that, but let's as an example, then you have to take those 100 frontline healthcare workers who are immediately taking care of COVID patients and say, okay, let's age stratify you. Let's go comorbid stratify you and try and make sure that people who are most vulnerable, and then we have to ask them if they want to get the vaccine. Because, we're not requiring the vaccination, we're offering the vaccination because it is under an EUA. We require influenza. We are not going to require this because it's not a fully FDA approved drug and we're in the middle of a pandemic. So we're going to ask folks how that's going to go. So sometimes you have to risk stratify a little bit more than to just say the first part of that. Yeah.
And then, just to address the availability of the second dose. So we know that initially there's going to be 6.4 million doses of Pfizer available. But what's happening is the federal government is actually holding half of those back because they want to make sure that you are guaranteed to get your second dose if you get your first. So they're kind of having separate supply chains to make sure that we don't mix it up and then all of a sudden not have enough to give the second dose.
And Danielle, as we look at this very question, one of the things I'm struck by is we're under the assumption that people can leave their job or do whatever to get back and get that second dose. Talk to us a little bit. How do we make sure that people are convinced that after they've had the first dose, they come back for the second dose?
Again, I think that's going to be important messaging from the point in which you get your first vaccination, that you're told, you're given flyers, you're given paper information and verbally told information. I think, again, we need PSAs. We need it to be banners when you check your Gmail account. We need commercials on the radio. Just to remind people that it's important. You have some coverage, but you need to get full coverage by the second vaccination. And I think to be able to work with your employer to say, I have a healthcare need and I need to go address it, and to have flexibility from your employer to make sure you get that second vaccination. Again, if we don't get vaccinated, we are all at risk. And then if we happen to get COVID, we're then shutting down our employment. So it's I think incumbent upon all of us at every level to make sure we support each other in being able to do the right thing and stay healthy, to make sure we still do the close of infection. I think you guys have all mentioned this, that the first vaccination doesn't get full coverage. So we need to continue to be steadfast in making sure we socially distance, we keep our mask wearing up, and we don't have mass gatherings until it's safe as a community to do so, hopefully in 2021.
Jill, last question.
Yeah, people are asking such good ones, so it's so hard to choose. I'm going to go with, because more than one person is wondering, they are also reading that vaccine companies will not be liable for people that are injured from the vaccine. And they want to know, is that true? And how do you weigh that in making the decision of whether to get the vaccine?
Okay.
Why are they not held liable?
All right, I got nothing on this one, I got to tell you. This is a legal question. I'm way over my skis here. Catherine, can you rescue me?
This is something that the federal government has a plan for. There is a program that actually addresses all vaccines and safety and injury claims related to that. I'll just keep the answer short, but there is protection for both those who get the vaccines and the companies who make the vaccines.
All right. Louis Satterwhite, final thoughts from today.
Final thought for me is that all this talk about vaccine is something that's really needed, because right now I'm feeling like we really need a light at the end of a tunnel. We're working with a group of people that are working just as hard as they can. I think in a lot of ways dedicated to keeping up the pace that they are. But there is a limit to how much somebody can just work harder and just work more. And so looking at these points in time where we might be in a better place is a whole lot more fun discussing than opening up that next ICU.
Boy, man, thank you. Catherine Satterwhite, final thought.
Final thought, I just want to thank everyone out there, and I mean everyone who's in the healthcare world, who is a teacher, who is everybody has made tremendous sacrifices, and I just want to thank you as a public health person. I know it's hard, and I know we have some more to do, and I know your families and have made tremendous sacrifices too. And I want to thank my husband, who I haven't seen since yesterday morning. He is on hour, 26, and I won't see him until tonight. So just thank you to everybody who is putting in the long hours, and that includes your kids having to put up with a lot of stuff that they wish they didn't have to either. So keep up the fight. I do think there's light at the end of the tunnel.
He is a pretty good guy, but we're not going to tell him that. Dr. Danielle Johnson, thoughts?
Final thoughts. This has been a long road and we're not through. And I think Dr. Satterwhite said this. We all need support. And so I know my colleague, Dr. Nawalnik, is heading up some groups for KU for support teams. And as a psychologist on the inpatient psychiatric adolescent side and outpatient adult and child side, just making sure that we all take care of each other, that we support each other, that we do those little things right now that are so important, leaving a tin of cookies on your neighbor's door because it's 2020, but being super thoughtful to take care of yourself in all the healthy ways that you possibly can, taking care of your neighbors as we best can, and looking forward to 2021.
Aren't we? Yeah, yes, we are. Yes, we can. Hawk.
Yeah, we will definitely keep up with the information from these severe reactions or anything else that happens around the vaccines as soon as that becomes available. I think we have to understand were these two patients together in the room? Were they at different facilities? Were they both actually severe reactions? We need to understand that first, and when we do, we'll be able to report that. But having been able to read through that FDA briefing, and I paid particular attention to the adverse events, I am even more encouraged now and optimistic that this is going to be a very good thing to get the vaccination because it does look extremely safe. Really, the biggest issue was the local site, so where the injection occurred, and it was mild to moderate pain for those. I know, again, with the influenza injection, I had some probably moderate discomfort for less than 24 hours. So that really seemed to be about the worst in the majority of the people who had things. We will keep up to date. We will keep letting you know, but after seeing that, I definitely was even more encouraged.
So tomorrow, U.S. Senator Jerry Moran joins us from Washington, D.C. to talk about the vaccine and answer questions. Impressive if he's really coming from Washington, D.C. and not his basement this time. I know his wife's been keeping him there a little bit. We look forward to that conversation. Send any questions you have for the Senator now to Medical News Network at kumc.edu, and we will get the list going. It's also been a while since we've sent since you've sent us mask photos. We got one yesterday. It's a great one. Ellie shared this photo of her son getting a checkup at the pediatrician's office yesterday. Ellie writes she appreciates the information shared during the updates, and we appreciate Ellie and everyone who watches and reshares that content. It is so necessary to reach out and talk about masking. It's still our number one pillar of infection control, right up there with distancing. Folks, think about the new era of COVID as a scale. There are a lot of questions out there about vaccines and are they safe and how will that go? And so that's one side of the scale. And on the other side of the scale is COVID. Where does the risk lie? Does it lie with COVID or the vaccine that's 95% effective, which is how we wiped out polio? It's how we wiped out smallpox, with very few risks. And then ask yourself this question. Which side of the scale does hope lie on? Does it lie on this side with more COVID? Or does it lie here with vaccines, distancing, masking, and doing the things we know that can keep us safe and get us back to normal? We'll be here tomorrow. Have a great day.